All right, let's jump into part 3 of the neurological assessment. And in this section, we're going to be talking about how to assess somebody's eyes, how to check that their neck is okay, and then taking a look very quickly for sort of gross patterns of pathological movement, seeing if anybody's got like a writhing athetosis or something like that. Again, these videos are available the PowerPoint's available for you to download and share non-commercially. Come to paramedicine.com. You can find out how to get the PowerPoint slides. All right, so let's talk about the eyes. And when we're talking about looking in the eyes, we've got to do some quick terminology. So the white bits around our eyes are called the sclera. The colored bits, brown in this case, or green or blue, or whatever color your eyes are, or the patient's eyes are called the iris. And then the black circle in the middle is called the pupil. Just remember, from outside to inside, we take a sip. Or if you want to go from inside to outside, you can use another acronym, but we'll take a sip. So outside is sclera, iris, pupil. All right? So just get those down before we start talking about what they do. So when we want to take a look at somebody's eyes, we're talking about checking if they're pearl. And what we're looking at is whether or not the pupils are equal and reactive to light. That's what pearl means. So we're taking a look at the pupils. They should be around roughly the same size. And when light is shone in them, they should react. Specifically, they should constrict, meiosis, so they get a little bit smaller. So if we're going to check somebody's pupils to see whether or not they're equal and reactive to light, we should be doing it in a slightly darkened environment. If you've got somebody who's been thrown from a car in the middle of the day in Australia in the sun, their pupils are going to be 2 or 3 millimeters. You're not going to be able to see if they react or not because they'll have shut down all the way, as much as they can. So if you're going to check somebody's pupils, usually we'll do this in the ambulance with the lights off. That's a way to do it. Or if you're in somebody's house, if they've got a bit of light coming through the window, you might turn off the overhead lights. If it's late at night, you might try to turn them down. But it's better to do it in a slightly darkened environment so that their pupils open up so that you can see if they react when we actually, shine a bit of light in there. If they've got glasses, have them take them off so you can see the pupils a bit more clearly. If they have contacts, it's okay. The pupils or the contacts aren't going to restrict the ability of the pupil to constrict and dilate. It's just that you get a bit of a glare off of the glasses. So if they have glasses, ask them to take them off. They don't need to focus on anything while you do this. So what you're going to do is you're going to take a flashlight. Please do not have one of those incredible laser beam type flashlights that you use to illuminate an entire house as you walk in. Like, don't use your flashlight for this. You should have a specific pupil light. So just taking a look gently with a relatively dim light, not like this blinding glare. I've seen paramedics sometimes use the flashlight or the torch on their phone. As long as you hold it away far enough, that's probably okay. If you intubate and you've forgotten all your lights and your phone doesn't have a flashlight because it's like from the 1990s, you can sometimes just use the laryngoscope if you want to, the light from the laryngoscope. But whatever light you use, it shouldn't be too bright, okay? So you're going to shine the light in a darkened room, or at least not very bright location, onto the patient's pupil and watch how it reacts, okay? So the pupil, when light shines on it, should constrict. It should tighten up. And we call that meiosis, getting nice and small. And when we see it relax because it's dark and open up, or because they're in pain, or because they're afraid, or because they're in love, then we call that mydriasis. Mydriasis means dilation. So if you can't remember whether meiosis or mydriasis means dilation, the word with a D in it means dilation. So mydriasis means dilation. When we are looking at people's pupils, that's right, in their eyes, and we shine a light, let's say I shine a light on my right pupil, you'll see that my right pupil will constrict as the light comes in, and we call that the direct response to the shining. So that's the direct response. But you'll also see, even if you put like a bit of cardboard or something on the other side, that even if we're not shining a light into the left pupil, both will actually constrict. So light into one eye will cause both to constrict. Grab a friend, give it a try. It's fun to play. So you'll see this is the direct response, and this one here is called the consensual response. It consents to respond along with the other one. So when you shine a light in one pupil, or if you've got a big light and you shine it in both, they'll both, regardless of whether you shine it in one or not, they'll both initiate meiosis. They'll both constrict due to the light. Okay? When you look at the pupils, initially they should be around the same size, and when you shine a light in them, they should constrict in the same way. The pupils are equal and reactive to light. And just about everywhere I've worked, people say pearl, or sometimes they'll say perla. Pupils are perla, and we'll talk about accommodation in a minute. So they should both be round, they should both be symmetrical, the same as each other, they should both be midline, and they should both be dark. People usually don't have bright pupils. If they've got whitish looking pupils, then those are cataracts that are sitting over the pupil and reflecting light off. Sometimes you'll see non-round pupils, and that's often due to direct trauma to the eye. This is David Bowie, and he was pretty famous for having groovy eyes. And the reason Bowie had interesting eyes like this, if you look closely at the picture, is he's just a normal blue-eyed guy. Well, Bowie's not normal, that's sacrilege, but he was a relatively normal person when it comes to his pupils. But then he got hit on his left eye when he was younger, I think, teens or 20s. And it blew out his pupil. It blew out his left pupil permanently. And you'll see that Bowie's left pupil, the iris is still blue, but there's not a lot of iris. There's just a lot of pupil. People sometimes thought that Bowie had different colored irises, but he didn't. Some people do. A lot of huskies do. It looks pretty cool. But humans have that too. But Bowie didn't. Bowie had a unilaterally permanently dilated pupil because of ocular trauma. And if you look at the picture, you can see that. So for some people, this is normal. This is a permanent state, usually due to trauma. That's not what most people are like. So trauma, surgery, being older, inflamed, there's a whole bunch of reasons that you can get this anisocoria. So under normal illumination in a not very bright room, we can go usually around 3-4 millimeters is normal. In a very bright light, pupils can go down to 1 millimeter, which is really small, and some pupils can actually get as large as 10 millimeters, which is quite big. So take a look at your pupils, see how they are, take a look at how they compare to each other. Any difference between the two of more than about a millimeter is a condition called anisocoria. And anisocoria can be normal or it can be pathological. I'm not going to read this whole thing, but about 20% of the population has normal physiological anisocoria. So, 2 out of 10 people that you meet, they'll have unequal pupils. If you're in a class full of other paramedics and there's 100 of you, start taking a look around and try and see if you can find the people who have unequal pupils. And if you can find them, then have a look at how they react, because normally they'll be non-equal, but equally reactive to light. So ask them if that's normal. I remember once meeting a woman, my ex-wife's teacher, co-teacher, and when I met her, she had these beautiful blue eyes, but one was much bigger than the other. And I said, have you been in like a car accident or anything? She said, oh, my pupils. I said, yeah. She said, oh, wow, you're fast. Most people don't realize that until after a long time. I said, well, I'm a paramedic. And she was like, oh, okay, that makes a lot of sense. So some people have it normally. In other people, it's abnormal. So usually people have pupils that are equal and reactive to light. And if they're not equal and reactive to light, and this is new for them, if they say, did anyone ever tell you that your pupils aren't the same size? I said, no, I was at my doctor's, last month, and they didn't say anything about that. Well, they are now. Then that suggests, doesn't prove, but it suggests that maybe their brain is not okay, which is the whole point of this lecture. So people should have pupils that are equal and reactive to light. Next thing we're going to talk about is conjugate gaze, and we're going to talk about tracking, which I already mentioned quickly. So when I'm looking at you, if I'm staring straight ahead, now I can't read the slide, of course, because I'm blind. If I'm staring straight ahead, both of my pupils should be at the same point in my eye compared to the inside to the outside. The pupils should be relatively midline. I don't have one pupil going off to the side and the other pupil in the middle. Now, some people do have that congenitally. And again, they'll be able to tell you that. So I think Marty Feldman was a famous comedic actor, and he had one eye off to the side. That was sort of part of his look, part of his shtick. But most people don't have that. They should be midline. And if my pupils are midline and something happens off to the side and I look, then both of my eyes should move to the same point on the inside of like my eyeball there. So if I do this and I look and my eyes are moving together, we call that a conjugate gaze. The eyes are moving to the same way in the same time, same place. So midline conjugate gaze. If I have one pupil and I look over to the side and one pupil goes like that and the other pupil just goes a little bit, that was what we would call a disconjugate gaze. And some people only have that when they move their eyes, and some people have a disconjugate gaze at rest. Basic rule is if they had a disconjugate gaze before, it's probably okay. If this is a new onset disconjugate gaze after someone headbutted them, then it suggests that their brain is not okay. And we talked about tracking. So as you walk in or as things happen around people, if they're sitting at the side of the road and cars are going by and they're looking at the cars going by, that's called tracking. And that's an indication that they are normally responding to the environment around them, which is a useful thing for us to pick up. Usually the only time I look at tracking is when I walk in. I take a look if the patient is looking at me and following me as I come into the room. So here's a standard sort of pupil chart. If you take a look at the top one, you'll see we've got Bowie eyes here. We've got a unilaterally dilated pupil. The right pupil is dilated. The left pupil looks about normal. Lots of things can cause that. Again, 20% of the population have normal physiological anoscoria, and that's just the way they are, and it's okay. But it could be head trauma, and we haven't talked about the cranial nerves yet, but we will. So if you already know about the cranial nerves, you know what I'm talking about. If you don't know about the cranial nerves, when you review the lecture, you'll understand, oh, that's where it came in. So the third cranial nerve, if it's being compressed by intracranial pressure, then it can dilate the pupil. The pressure on the nerve will cause the pupil to dilate. Or like Bowie, something could have hit your eye, or maybe you drop medication in your eye. You know how you go to the ophthalmologist and they drop those drops into your eyes and your pupils dilate totally so that they can look into your eyeball? Well, if they only drop it into one, it's going to be really blown out. Or if you're a really incredibly sloppy paramedic and you accidentally, splash atropine or ipratropium bromide or something like that into somebody's eyes, you should never do that. But if you do, then you'll notice that they'll have a unilaterally dilated pupil. What about bilaterally dilated pupils? This is often very normal. So with a sympathetic discharge, if you're afraid, if you're in pain, if you're in love, then your pupils will dilate. And it's actually one of the reasons. I don't know if I want to get into all sort of evolutionary psychology, but interestingly in evolutionary psychology, I guess I will, we talk about people who have blue eyes as being more beautiful. And they're not. I mean, beauty's in the eye of the beholder, pardon the pun. But why would we consider people with blue eyes somehow to be more attractive? The reason is, physiologically and developmentally, if you look at somebody who's got dark eyes, so they've got a very dark iris and it's difficult to differentiate the iris from the pupil, then we say they're inscrutable. You can't really tell how they're feeling. But somebody who's got blue eyes, like the person in the diagram here, you can tell if they're dilating or not. So if you're with, someone you're attracted to and you're trying to figure out whether they're attracted to you or not, and they're laughing and they're touching your arm and they're doing the whole thing and their pupils are dilated, you're in because they're excited or they're really afraid, or both. Who knows? I'm not going to judge people. Do how you want. But those sorts of broad sympathetic discharges can cause dilated pupils. Also, there's some pathology that can cause it, usually in the midbrain. So epilepsy, stroke, bilateral trauma, tumor that's compressing bilaterally the third cranial nerve. So there's pathology that can cause this as well. But don't be surprised if you go to a call and someone slid off their, brand new Harley. They're driving it off the lot and it slid into the river and $35,000, $40,000 fell in the river. And they're just sitting there like this with their pupils totally dilated. It doesn't necessarily mean that they bashed their head. It means they're thinking, how am I going to explain this? How, is insurance going to cover this? If they're really scared, they're often got dilated pupils. Okay, so irregular pupils, usually from direct orbital sort of trauma, either from that incident or historically. So if you notice that somebody's got an irregular pupil, ask them about it, whether it's new or whether it's historic. And if it's new, brain's probably not okay, which is what we're looking for. We've talked about conjugate and disconjugate gaze. There's kind of a subtle view of a disconjugate gaze. You'll notice that the eye, as we're looking at it on the right, is further towards the midline than the eye that we see on the left is towards the outer part of the eye. So instead of moving like this, they've kind of moved like this. This one's in a lot more. This could be, again, be historical, congenital, or it could be a problem in the frontal lobe. And then finally, pinpoint pupils. Lots of things can cause this. As people get older, they tend to get more pinpoint pupils. What do we call that? Oh, I forget. Anyway, there's a fancy medical name for it, but older people tend to have smaller pupils. It could be pontine and pons injury, like brainstem injury. Narcotics can cause this, but not all narcotics. So if somebody does not have pinpoint pupils, you can't say, well, then they for sure did not take any narcotics. They still might have, because not all narcotics will cause pinpoint pupils. Smoking, nicotine will cause this. Some antipsychotics, if you carry haloperidol, droperidol, drugs like that will constrict somebody's pupils. What else? Ondansetron, an antiemetic, monoamine oxidase inhibitors, organophosphates, blind as a bat, right? That toxidrome. So those things can cause pinpoint pupils. All right. The eyes and nystagmus. Nystagmus is just a jiggling of the eyeballs, and they can jiggle side to side, or they can jiggle up and down, or they can jiggle in a circle. It's not terribly specific, but the definition here, rhythmic, regular oscillation of the eyes. And I put up the YouTube because I can't do nystagmus. I can do it a bit. Everybody can. If you look at the very edge of your range of eye motion, then your eyes will start to jiggle a little bit. So you can try that with your friends. That's fun. But if you really want to see good examples of nystagmus, then just go onto YouTube and type in nystagmus and start looking for examples of it. So there's vertical nystagmus, there's horizontal nystagmus, there's rotary nystagmus, and there's what I was just talking about, the normal fine nystagmus at the extreme gaze ranges of gaze. So if I look like this, I don't know if it'll show, but this is the way you would do it. You'd look, yeah, I can see the screen jumping up and down in front of me. So that's nystagmus. Nystagmus. I was saying nystagmus. Nystagmus. So there's different types of nystagmus, lots of potential causes from it: toxicology, inner ear problems, central nervous system problems, drugs, alcohol, all sorts of things can cause it. Again, we go back to the general rule. If they've always had nystagmus and they still have it, same as before, it's probably not a problem. If they've never had nystagmus before, no one's ever mentioned it, and they have it now, maybe their brain's not okay. Maybe we should get them checked out more. Okay. Last thing is accommodation. So what you'll do in accommodation, again, take the glasses off so you remove the glare. You ask the person to look far away, look towards the horizon, and then put your finger like around a thumb distance from their nose or a little bit more, and ask them to follow your finger as you bring it in. Now, as they do, what'll happen, I can't see it very well with me. I've tried playing with the light, but I can't do it. Camera won't pick it up, is their eyes, of course, will cross. So, as you look at something close, your eyes cross. And the other thing is the pupils will constrict. That's normal. So when you look far away, your pupils dilate a bit more because you're trying to collect more light to see what's far away. And then as your finger comes close, you accommodate your focus and your pupils cross and constrict. So cross and constrict. That's the secret of what accommodation is. I've asked this on an exam for the past few years and nobody ever remembers accommodation. But remember when I said we talk about pupils being pearl, or sometimes we say perla? Pupils are equal and reactive to light with accommodation. So you test accommodation, ask them to focus on your fingers. That's called accommodation. And here's an example. The picture down there without the finger is somebody looking far away at the horizon. And then when you put your finger nice and close, you can see that their eyes have crossed and their pupils have constricted. This is an example of normal. This is what eyes should be doing. Okay. So that's how we check the eyes, and then we're going to check for movement, just like gross ocular movement. And the way we do that is we hold a finger around, an arm's length away from the patient, and we ask them to follow your finger. I'll do this a little bit more constricted so you can see it. Normally it'd be out sort of towards the edge of their vision. But you draw an H. So you just kind of do this, a capital H. And as you do this, I don't know if you can see me do it, but I'll follow the finger over, I'll follow it up, I'll follow it down, I follow it across, I follow it up, I follow it down. And we're just looking for extraocular motion. We're just making sure that the eyes can move all the way around in the visual field that they can normally cover. They should be able to do that. That's normal. Next thing we'll talk about is something called neck stiffness. So let's switch away from the eyes. We've done perla and we've done extraocular motion. And now we're going to switch to neck stiffness, because one of the things that can happen is if you have an infection of the central nervous system, well, then your brain is probably not okay, right? If your brain is infected, it's probably not okay. So how can we tell if we have an infection of the brain? Well, one of the ways is to check to see if the covering over the brain and the spinal cord, which are called the meninges, if they're inflamed, they'll tighten up. And as we stretch those meninges, it'll hurt. So because I don't have meningitis right now or meningeal inflammation, I can move my head around and it's okay. But if I asked you, what we'll typically ask a patient is, close your mouth, keep your jaw tight, and then try and touch your chin, keeping your mouth closed, down to your chest like this. And if they go, oh, and there's this sort of a cogwheel rigidity, then what's happening is as they bend their head forward, it's stretching the meninges along the back of the brain and their spine, and it sends pain signals to the muscles. The muscles go, ow, stop it. So you stop it and you go, hey, muscles, no, I want to do this. Let me do it. And they go, ow, stop it. And you get this tick, 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 like a cogwheel rigidity, or sometimes called knuckle, as I've heard it pronounced, nuchal rigidity. So is their neck stiff? There's a lot of different ways that we can test this. So we're looking for meningitis. When we talk about meningitis and you read the literature, they talk about fever, headache, and neck stiffness. Those are like the three classic signs of meningitis. But when you actually read more about it, and if you download the PowerPoints for this, I've got references in the speaker's notes. So there are, I'm not all making this stuff up. There actually are references to it. So you can download the PowerPoint and see the references. When we take a look at how specific indicators the fever, the headache, and the neck stiffness is, it's really weak. It's got a positive likelihood ratio of like 0.92, negative likelihood ratio of like 0.88. So that's like the rule in and the rule out. Both of those are almost essentially 1, which means you might as well flip a coin, because a coin has a likelihood ratio of like 1 of landing either heads or tails. It's 50-50. So these aren't really good predictors. If you see them, it tends to make us a bit suspicious, even though, the epidemiological math behind it isn't really great. But we do get worried. If someone goes, oh, ow, yeah, oh, that really hurts when I do that, I would be very uncomfortable leaving them in the community without follow-up, especially if they have signs of infection or if they've had altered mental status or anything like that. I think it's rare that you'll find a cautious clinician that would leave someone with real neck stiffness without follow-up. So there are a few ways we can test. There's Kernigan-Brzezinski sign, which you'll read about. Again, not terribly specific. Difficulty touching the chin to the chest with the mouth closed is more specific, but the most specific, and what I like to ask my patients to do, as long as they're not kyphotic or obese, or as long as they have the ability to actually move their body, is I ask them to try and touch their forehead to their knee with their mouth closed. Just do that. And if they go, oh, sorry, I can't quite make it, but they're not going, ow, then that's okay. If there's a lot of pain when they stretch their meninges, then I'm worried about meningitis. So let's take a quick look at this. Brzezinski sign is the one at the top there. If you tilt someone lying flat on your stretcher, you tilt their head up and their knees come up to try and compensate for that stretching, that's called a positive Brzezinski sign. Or the Kernig sign is if you're flex their knee a little bit and try and lift their knee up, and it's very painful to them and uncomfortable in the hamstrings along the bottom of the leg or the back of the leg between the knee and the bum, then that's called Koenig's sign. And that is a not terribly specific assessor for meningitis. Your best assessor for meningitis, forehead to knee with the mouth closed. Okay. Last one, we'll talk about gross movement disorders. And these are, sort of large muscle motor movements which are abnormal. This is the part of the lecture that my students sometimes call the Ministry of Silly Walks part of the lecture. So there can be a tremor. Sometimes you'll see people and they'll talk to you and they'll be doing something like that. Or when they reach out for something, then their hand really starts to tremor, do this sort of a shaking motion. Those are called tremors. The head and the limbs are usually where you see that. You don't really see central torsal tremors so much. It tends to be in the extremities. Look for tremors. Tremors are not normal. You might see myoclonic jerks, and a myoclonic jerk, which I've always thought would be like the perfect name for a rock band. You get a bunch of medics and nurses and doctors and call yourself the myoclonic jerks. Perfect. So a myoclonic jerk is when someone's talking to you and they start to do, these sorts of things. Everybody gets myoclonic jerks when they go to sleep because we're polarizing our motor end plate. So if you're lying in bed and you do that sort of a thing, that's a myoclonic jerk, and that's normal. But if you're doing it after a car accident when the paramedic is talking to you, that's not so normal. So look for myoclonic jerks and see if people are doing this sort of a thing when they're talking to you. You may see a tic. So I have a tic. If you've watched a lot of my videos, you'll notice that I'm constantly doing this sort of a thing because I got a really bad neck. So once you see it, it cannot be unseen. But tics are something that you'll see people doing, or they might, have a little thing like that. I was talking to my friend and they did the thing, and then they did the type of, that's a sort of a tic that someone will have. Akathisia, you'll often see, people are sitting and talking to you like this, often be tapping their foot, which I can't do on the camera, but, tapping their foot or kind of rubbing their hands together. I'm really nervous because this thing happened, and literally means they can't sit still. So if you see somebody moving like that, that is, again, an abnormal motion, gross motor movement for somebody to have. Then there's athetosis, which is a writhing sort of a thing, and you'll sometimes see people who talk to you like this, and they're usually like flexion, extension, writhing, often in the hands and in the face a little bit when they're talking to you. So that's like an athetosis, sometimes called a writhing athetosis, just these like slow, sinuous movements is a great way to describe it, of just, moving around. And the last is dystonia. There's some really good videos on YouTube for dystonia. This particular one, this young woman has really bad dystonia. Normally she's okay, but she's got a great video, and I thank her for putting it on the internet so we can all see it, where she has a really bad dystonic attack and she's trying to walk, and it's just a gross, sustained contraction of large muscle groups, and you can't walk. You can't, it's really painful. It's just a terrible condition. So go onto YouTube, take a look at that, but you can see people with dystonia as well. Okay, so we've talked about eye, we've talked about neck, the eyes, the neck, and we've talked about gross abnormal movements. If you got any questions, put them into the comments for me and I'll look for them there, okay? Thanks a lot.